Hello everyone. So now we are going to discuss tinnitus, which is basically the sensation of ringing sounds inside the ear without a usual clear source. So the first thing that you need to ask this patient is, can you please describe these noises for me? Okay, this is because you want to assure whether he or she is hearing sounds. Are these just sounds, or he is hearing voices? Okay, so this is basically to differentiate auditory hallucination from tinnitus, which is just ringing sounds. Okay, the second thing is, can you please tell me a bit more about it, and in which ear can you hear these ringing sounds? Okay, so you need to ascertain whether this is unilateral or bilateral. So, regarding the differential diagnosis, the most common six differential diagnoses I have written here. So, most commonly, tinnitus is idiopathic. This is the most common cause of tinnitus, okay? And it's harmless in those conditions. The second most common cause is due to earwax, okay? So, earwax. And it can be in some form of hearing loss, like sensorineural hearing loss. The patient can also experience tinnitus. Also, in Meniere's disease, as you already know, we have discussed in the previous video that in Meniere's disease, we have vertigo, tinnitus, hearing loss, and sensation of fullness in the ear. Okay. Another cause is tympanic membrane perforation due to trauma. So, for example, a person is exposed to very loud noises, or he or she is taking, they are traveling by ear, and during takeoff or during landing, due to sudden pressure changes, they experience tympanic membrane perforation. So that is one of the causes. These two causes that I have written in red are basically the red flag causes that you need to watch out for. One is acoustic neuroma, okay, and the other is vascular tumors, okay. So acoustic neuroma is cerebellopontine angle tumor. We have also discussed it in the previous video, and it's cerebellopontine angle tumor, and it present with symptom of ear disease like hearing loss, tinnitus, vertigo, and facial weakness and numbness or pain in the face. Okay, vascular tumors, there are some vascular tumors which are also called glomus tumor, and they also present with tinnitus. And because these are vascular tumors, tinnitus in these cases coincide with the patient's pulse. Okay, so vascular tumors you also need to look out for. Okay, while taking history of presenting illness, of course, first of all, you will ask the patient to describe these noises and to differentiate between tinnitus and auditory hallucination. Then you will ask which ear, one ear or both ears, okay? And then you will ask Odipara, onset, duration, intensity, progression, aggravating factor, relieving factor, and anything else. Okay, so in anything else, you will ask the DD questions, any hearing loss, okay, any dizziness, any weakness in the face, any numbness in the face, any ear pain, any ear discharge. So ear pain and ear discharge, they will be there in ear, in tympanic membrane perforation. Numbness, weakness in the face, they will be there in acoustic neuroma. Dizziness or vertigo will be there in Meniere's disease. Also, it will be there in acoustic neuroma. Hearing loss will be in sensorineural hearing loss or earwax. Okay, earwax also causes, conductive hearing loss. Any chance you hurt your head recently? So again, this is traumatic tympanic membrane perforation. Are you exposed to loud noises on regular basis? This is also because the exposure to loud noises on regular basis cause sensorineural hearing loss. Do you feel like it coincides with the pulse? This is to rule out vascular tumors. And how is it affecting your mood? This question is very important, okay? Because tinnitus for a long time, if you imagine that a person is hearing these ringing sounds out there all the time, 24/7, and no one else is hearing it, then it's definitely going to be very irritating, and it's definitely going to affect their mood as well. So this is very important to ask that this has been going for a while. How is it affecting your mood? Okay. So this was your history of presenting illness. Then you need to ask past medical history, maftosa, which is medication, allergies, family history, psychosocial, then lifestyle questions, that is smoking, alcohol, diet, and exercise. After this, you need to ask about ideas, concerns, and expectations. And after that, you need to verbalize your examination. So examination will include observations or vitals, and you will examine the ear with otoscope, and you will also perform hearing test with a tuning fork. Okay, so you need to verbalize these three investigation vitals: examination of your ear with an instrument which is called otoscope, and hearing tests. So regarding management, as you all know that we start our management with explaining the condition to the patient in simple words. So you will tell the patient that you have a condition called tinnitus. It means that you experience noise in one or both of your ear which do not have an external source, so other people can't hear it. Okay. So if you find out any of the cause during history taking, so you will explain that this is the cause of your tinnitus. If you can't find out any cause, then of course you'll tell the patient that it can be because of unknown reasons as well. Okay. So okay. So let's talk about when are you going to refer this patient, when is immediate referral, when is urgent referral, and when is routine referral, and when you only need to reassure this patient. Okay, so immediate referral to ENT so that they can be seen by the ENT specialist within few hours will be under three conditions. Number one is if the patient is so depressed and so irritated because of the tinnitus that he is at high risk of suicide. Then you will refer this patient not to ENT but to mental health services. Okay. Mental health services will provide them a safe place, and will try to stabilize them mentally while they are waiting to be seen by the ENT specialist. If there is history of head trauma and the patient is experiencing tinnitus, then you will refer immediately for them to be seen within few hours by the ENT surgeon. And if there is acute onset vertigo or facial weakness, if there is acute onset vertigo, acute onset tinnitus with sudden onset of vertigo or facial weakness, it means that the patient is experiencing posterior circulation stroke. Then again, you need to refer immediately to the stroke services. Okay. So mental health services, ENT surgeons, and stroke services or neurology specialist. When are you going to refer them on urgent basis for them to be seen by the specialist within 2 weeks? If it's affecting their mood, but they are not suicidal. Okay. So you need to ask this question in the history, how is it affecting your mood? And you need to assure how much is it affecting their mood. Okay. So if it's only affecting their mood, but they're not suicidal, then you are going to refer them within 2 weeks. Okay. If there is any hearing loss associated with the tinnitus, then referral within 2 weeks. If there is any earache or ear discharge. So there were three symptoms which warranted immediate referral, and it included number one, acute onset vertigo and facial weakness, and the second one was if there was head trauma, and the third one was if there is suicide risk. So suicide risk, head trauma, and acute onset of vertigo and facial weakness. Urgent referral, it also includes three symptoms. Number one is affecting mood, number two is hearing loss, and number three is earache or ear discharge. Routine referral, if there is persistent unilateral tinnitus. Okay, so if there is tinnitus, which is in one ear, which is not bilateral, and it's been there for quite some time, like one month, 2 months. So persistent unilateral tinnitus, you need routine referral. If the patient does not fit in any of the above situations, for example, if there is bilateral tinnitus, okay, and there is no other symptom associated with it, there is no hearing loss, there is no vertigo, there is no facial pain, no facial weakness, no numbness, it's not affecting their mood at all, no earache, no ear discharge, there is only tinnitus, which is bilateral. Then what you need to do, you need to reassure the patient, tell them that there is sometime it happens on its own and resolve on its own. There is no known cause for it. And you need to reassure this patient that it's basically a harmless condition in your case. You can, if it's bothering them, then you can also refer them to tinnitus related CBT, which help these patients. So basically, we'll tell the patient, we will refer you to one of our counselors that will tell you different techniques to cope with it. You will tell them to relax, do yoga, meditation, anything, any hobby that basically relaxes them, because stress can basically exacerbate this condition. Tell them to avoid complete silence, because in complete silence, they're just going to focus on their tinnitus. So tell them to keep listening to some soft music, or they need to have some background level of sound in in all the time, and avoid anything that triggers it. So this was basically all about tinnitus, and if you like this video, then please let me know in the comments, and I will see you soon with the next video.